Well, thanks for the opportunity to speak at CVI Digital Edition 2020. I will be discussing some considerations for performing PCI in the COVID era. Myocardial injury has been reported in approximately a quarter of patients hospitalized with COVID-19. And the presence of troponin elevation, it's a marker of higher mortality. Early reports indicate that patients who have ST segment elevation in the setting of COVID-19 have shown a variety of findings, including normal coronary arteries or typical findings seen in STEMI patients. Patients with cardiovascular risk factors or established cardiovascular disease are also more likely to experience severe or critical COVID-19 illness, requiring ICU and advanced therapies. There are many aspects of STEMI care that we don't know about COVID, in particular as it relates to who needs to come to the cath lab, what are the most common angiography correlates, and the best treatment strategies. It's also clear that COVID-19 is affecting the care of non-COVID patients. With that in mind, the Society of Cardiac Angiography and Interventions and its Canadian equivalent, along with the ACC Interventional Council, started a prospective registry called NACMI to better understand the management strategies and the angiographic correlates of patients who present with ST segment elevation in the setting of COVID-19. Persons who are under investigation or PUI are also included in the registry. And the main goal of this registry is to compare the demographic, clinical characteristics, and outcomes, including management strategies, to those patients who have been treated for STEMI as part of the Midwest STEMI Consortium, which is going to serve as a control group. The Midwest STEMI Consortium is a collaboration of 4 high-volume PCI centers in the upper Midwest, as shown here. The inclusion and exclusion criteria for NACMI are listed here and are very simple and include the presence of ST segment elevation on the onset left bundle branch block on a 12-lead EKG and patients who are over the age of 18. We also want to have a clinical correlate of myocardial ischemia, understanding that many of these patients are going to present with cardiac arrest in shock or are going to be under mechanical ventilation and may not have typical chest pain syndrome. We have no exclusion criteria. These are some of the pathways by which a patient can get into the NACMI registry. Patient 1 on the left has a clinical diagnosis of coronary myocardial infarction on the basis of the EKG that shows inferior Q waves with residual ST segment elevation. This patient underwent PCI of the right coronary artery, but later on was ruled out for COVID. Because he was a PUI, this patient is included in NACMI. The second patient had a Brugada type ECG on admission. He had, in the setting of fever, a clinical diagnosis of non-coronary MI, and this patient underwent no reperfusion therapy. It's also eligible to participate in NACMI. And finally, on the right, a patient with a typical anterior myocardial infarction underwent pharmacological reperfusion followed by mechanical reperfusion. This patient also it's eligible to participate in the registry. So far, as of June 2020, we have 112 cases, including from sites in the United States and Canada, as shown here, which is remarkable. About a third of these patients are confirmed COVID-19 cases. The remainder are PUIs. Another important consideration is who needs to come to the cath lab as it relates to the well-being of healthcare workers. About 13% of cases in some European countries have been related to healthcare workers contracting the disease in the hospital. This is something that, as you know, has been investigated and widely reported due to shortages of PPE, particularly in the early phase of the pandemic. And there's also been shortages in testing materials and long turnaround times, which is present even to date, and this has made clinical care difficult because of these patients coming into the cath lab without a firm diagnosis. In that context, some have advocated for modified reperfusion strategies for COVID-19 patients who present with a STEMI, arguing that about 13% of STEMIs already are receiving pharmacoinvasive therapy, and that the benefits of this therapy, if given within 3 hours to low-risk patients, are similar to mechanical reperfusion. This strategy also has the potential to mitigate delays in reperfusion associated with testing and triaging of patients in the emergency department. And therefore, door-to-needle time may be quicker than door-to-balloon time in these situations. Of importance, this modified reperfusion strategy retains the possibility of crossing over to PCI for high-risk patients or those who fail pharmacological reperfusion. I must say that in the United States, both ACC and the American Heart Association still recommend primary PCI as the main reperfusion strategy for patients who are COVID-19 positive or PUIs. The early experience in New York City with limited number of patients is very informative. Approximately half of these patients presented with ST segment elevation. The remainder had ST segment elevation during the index hospitalization, but not at the time of admission. Only a third of these patients had chest pain. The majority had fever, cough, or shortness of breath. In terms of management strategies, 50% underwent angiography. The majority of those patients underwent PCI. Those with obstructive CAD here, 6 out of 9. The overall mortality was very high at 72%, and it was present both in patients who were diagnosed with a typical STEMI and patients that had a non-coronary myocardial injury. This diagnosis is very hard to make on the basis of ECG alone. This distinction is usually done with a combination of clinical factors, ECG, biomarkers, and imaging. As shown here, patients who have a typical STEMI tend to have higher levels of troponins and D-dimers, and also tend to have regional wall motion abnormalities in the setting of a depressed ejection fraction relative to patients without a typical STEMI or a non-coronary culprit. It is clear also that COVID-19 is affecting the care of non-COVID patients. We have previously shown that there has been a significant 38% decline in STEMI activations. The reasons are not entirely clear. Some have argued that this could be related to less pollution, as shown in this study in Italy, where the levels of STEMI activation correlated with decreased levels of pollutants, including fine particulate matter and nitrogen dioxide. We're not so sure that's the main reason. We think that many of these patients are having their STEMIs at home and could be having out-of-hospital cardiac arrest as the first manifestation of cardiac disease, as shown in this study in France. Significant increase in the number of cardiac arrests at home during the pandemic. And this has also been shown in New York City. So this is a concerning signal that we're trying to better understand and hopefully reverse as the pandemic continues to affect STEMI care. In summary, COVID-19 seems to be affecting multiple aspects of STEMI care, and observational registries such as NACMI have the potential to provide actionable data that can be relevant to patient management and hopefully can inform decision-making going forward. Thank you very much for your attention.